but not least is Cody Tuftee in the BME program in Dr. Mohammed Rizwan's laboratory, presenting cornea glue. Don't just seal, heal.
Now, imagine you have a daughter named Christy, and one day she's playing in the sand, and you hear a terrible screech, and she's in tremendous pain, so you take her to the hospital, where a doctor there tells you that a grain of sand has lacerated her cornea, and scarring will soon steal her sight. Now, corneal scarring is one of the leading vision-related disabilities worldwide, and our only retroactive treatment for it is a cornea transplantation. It can be caused by a variety of ocular diseases, such as cataracts, fungal infections, or the like. Now, with transplant surgeries, there is, of course, the limitation of donor tissue shortages. And in the case of the cornea, there exists less than 1 cornea per 70 victims. This means that our surgeries and recoveries have to be precise and done with care. Now, within corneal surgeries, there perform lacerations along the periphery of the cornea that are later sealed with sutures or the like. And as we see in the bottom left, sutures can cause additional damage to the cornea and stimulate their own fibrotic response, counteracting the surgery we just performed. Additionally, commercial sealants such as fibrin glue seek to aid this, but because they focus on sealing the cornea, they inhibit infiltrating cells, which increases the risk of transplant rejection. Now, my research seeks to develop a corneal glue that doesn't just seal, but also heal. To do this, I've devised a 2-pronged strategy with enhancing cell infiltration and repopulation of the wound, as well as reducing the fibrotic process to facilitate scarless wound healing. To increase cell infiltration, I engineer interconnected porosity by fabricating gelatin hydrogels, or water-based gels, into microspheres and jamming them into a granular hydrogel, as seen in the SEM image in the top right. Now, similar to volleyball stuffed into a bin, there exists an interstitial space between each of our microgels that allows cells to migrate into and throughout the scaffold with little to no resistance. When placed in the cornea, the scaffold also becomes an artificial aid to regenerate the lost tissue. Now, the fibrotic process within the cornea mainly consists of our resident cells being transformed into inflammatory myofibroblasts. By engineering the sustained release of the anti-inflammatory cytokine interleukin-10, I aim to block transforming growth factor beta, which is primarily responsible for cell transformation. And I can engineer this within my adhesive glue by simply subbing out subpopulations of microgel within the scaffold. The combination of these 2 strategies seeks to create a surgical sealant to help little Miss Christy get back to her days and restore her vision. Thank you.